Welcome to Nurse Practitioner Week. The presenters for this session are Amber Littlefield, DMP, FNP, Masters in Education. Dr. Littlefield is an instructor at Frontier Nursing University and has been a nurse practitioner for 6 years. She holds a master's degree in education, a master's degree in nursing, and a postmaster's certificate as a family nurse practitioner. She obtained her doctorate of nursing practice from Frontier. Her clinical experience as a nurse practitioner includes emergency medicine and aesthetics. Today, Dr. Littlefield spends the majority of her time teaching future nurse practitioners the art of being a nurse practitioner. The second presenter for this session is Joanne Keefe, DMP, Master's in Public Health, and FNP. Dr. O'Keefe is an instructor at Frontier Nursing University and has been a nurse practitioner for 4 years. She received her MSN and DMP at Frontier and holds a Master's of Public Health. Her clinical experience as a nurse ranges from research to ICU. Today, Dr. Keefe spends the majority of time teaching and maintains a part-time clinical practice providing walk-in care.
Hi, I'm Dr. Amber Littlefield, joined by Dr. Joanne Keefe, and we are here to present encouraging culturally competent care to the LGBTQ patient. So let me begin with a disclaimer or disclosure that Dr. Keefe and I are not members of the LGBTQ population. However, we are advocates for this population. Therefore, as we don't personally experience these disparities, we encourage any advice from the LGBTQ population on how we can improve care. So here's just a little bit of what we're going to talk about today. Let's begin with the population. LGBTQ stands for lesbian, gay, bisexual, transgender, queer, or questioning. There are about 3.8% of Americans that identify as LGBTQ, which equals approximately 9 million Americans. Of these, about 2.7 million are over the age of 50, and approximately 1.1 million are over the age of 65. Just like the general population, the LGBTQ population is aging, which increases the need for health care. The Institute of Medicine, or the IOM, identifies LGBT adults as an at-risk and underserved population. The LGBTQ patient is subject to stress and microaggressions, which are increased if they are also a person of color. So health disparities overall. There tends to be a decreased rate of health insurance and preventative care, as well as cancer screening in this population. There's an increased risk of interpersonal violence, drug and alcohol abuse, homelessness, and suicide. Again, these risks increase when the person is also a person of color. It is estimated that between 29 to 30% of the LGBTQ population avoid health care. That's compared to about 17% of the general population. So health disparities that are specific to lesbian patients. Lesbian patients are twice as likely to be obese and therefore also at risk for obesity-related comorbidities, such as type 2 diabetes, coronary heart disease, stroke, osteoarthritis, breast and colon cancers. This is also related to their decreased incidence of childbirth. They tend to underutilize preventative care and are 10 times less likely to be screened for cervical cancer. So as a provider, it's important for you to not assume that these patients do not have sex with men or that they have never had sex with men. They are at risk for sexually transmitted diseases, just like your heterosexual patients. They are more likely to smoke and therefore more at risk for diseases such as cancer and COPD. Health disparities specific to the gay male patient. Gay men have higher HIV rates and other STD rates than the general population. While men who have sex with men account for only 2% of the population, in 2009 they accounted for 61% of the new HIV infections. Long-term use of antiretroviral therapies have been associated with an increased risk of cardiovascular disease. They also have higher risk of co-infection with hepatitis B and C. They are at a higher risk for HPV and HPV-related anal cancers. They're more at risk for social isolation, especially as they age. They are twice as likely to live alone and have fewer children than heterosexual men. Health disparities that are specific to your bisexual patients. Patients who are bisexual have higher rates of suicidal ideation and suicide attempts. They have increased rates of depression, intimate partner violence, obesity, and overall dissatisfaction with life. So these are the things that you need to be aware of when you're treating a bisexual patient. Moving on to the transgender patient. Transgender patients are the least likely to have health insurance. They have HIV infection rates that are 4 times higher than the general public and higher rates of violence against them. Of the LGBTQ population, your transgender patients are likely most at risk for health disparities. So before Dr. Keefe goes on to talk about how we can improve care and how we can make our clinics a safe place for the LGBTQ population, I thought it was important that we talk about the current state with these patients. So in order to understand why the LGBTQ patient may not feel comfortable seeking health care, I think it's important to look at the history of discrimination against them. So in the 1950s, same-sex affairs were viewed as criminal. Many states had sodomy laws. In fact, in 1961, Illinois was the first U.S. state to stop sodomy laws. Also in the 1950s, the American Psychiatric Association classified homosexuality as a psychiatric disorder. In 2012, Don't Ask, Don't Tell was repealed. This was the Clinton administration's ban on gays, bisexual, and lesbians from serving in the military. Statewide protection in employment, housing, and public accommodations remain absent in over half the states in the United States. Same-sex activity is still considered illegal in over 70 countries, and in some of those countries, it is punishable by death. The Defense Against Marriage Act, also known as DOMA, prohibited same-sex couples from collecting federal benefits, including health insurance. This was just overturned by the Supreme Court June 26, 2015. So this is why they fear seeking health care, because sometimes there's discrimination that they have faced and they may be fearful of seeking health care. And now Dr. Joanne Keefe.
Thank you. This is Dr. Keefe, and I'll be going into some of the terminology, ways that we can make our clinics more inclusive, and ways that we as providers can offer inclusivity, and the ways that we can work with our patients in a better way. The first thing to talk about is the terminology, just so that we understand some of the basic ideas that are being portrayed here. The first thing is to learn a little bit about the terminology, but the best thing to do is to let the patient take the lead in terminology. Some may like the term queer, and some may dislike the term queer. So it's not an assumption that you can just learn one kind of terminology and have that be okay for everyone. Partner in general is a good term, but some patients may want you to call their spouse a husband or a wife. It's been a long, hard fight for them, and that may be an important thing. So let them take the lead and then follow that. Some of the terms that we're going to kind of talk about and unpack here is birth assigned sex, gender identity, gender expression, and then attraction and sexual orientation. All of these different terms make up a very complex identification of sexual identity for a patient. And so let's pull them apart just a little bit. The birth assigned sex is how a person is born, and that could be genetic, it could be a physical manifestation. It's important to know that this is not binary, although birth certificates do have male or female boxes to be checked. It's actually not as binary as you may think, just being male or female. These are important things to know related to sexual health issues. Does the person need a pap smear? Those sort of things that will help you to determine what they actually need genetically and physically, what they might have. The next thing is gender identity, and this is the way a person feels inside about the gender that they are. This can include male, female, or non-gender. Somebody may actually feel like they don't want to express or to identify with a gender. This is, of course, not binary either. It's more on a continuum. When we talk about this is when we start talking about transgender. Transgender is actually where the birth assigned sex and the gender identity don't move in the same direction. So somebody is feeling different inside than the assigned sex that they had at birth. That's transgender in a nutshell. Transgender is actually a self-identification term, and it begins to identify the person when they feel that inside of themselves. That's basically when you accept that as what it is. You may hear the term cisgender, and that's where the gender identity and the birth assigned sex are the same. Then we talk about, well, let me say this, transgender, their thinking is about 0.1 to 0.5% of the population. It seems to be the topic that most people are confused about and need most information in, but I want to assure you that that's such a small percent of the population that, I think it's important if you're inclusive to think about it, but it doesn't need to be the focus of everything that we talk about today. Then we talk about gender expression, and that is the way that the person expresses their gender. So this may be the way that they dress, the way that they wear their hair, the way that they walk, the way that they talk, and some of the terms that you may be familiar with when we talk about gender expression are butch, femme, and then there is also the neutral. So once again, it's on a continuum, and this gender expression can be different from a gender identity and birth assigned sex. And then we talk about attraction and sexual orientation, and this is about who the person is attracted to sexually. Don't assume any behaviors, as Dr. Littlefield said. People who identify as lesbian may indeed have sex with men, may have in the past, and may currently have sex with men. Women partners who identify as women may have a penis, and then in the relationship there may be a need for pregnancy prevention, and it's all about the identification and how that all works. So don't assume anything. That's something that will come up throughout this presentation. If you don't make assumptions, it's the best way to go. Remember that gender and sexuality are fluid, and people may identify and express themselves differently through their lifetime, and it may even be from week to week. Someone may feel differently and want to express themselves differently as they're going through different ways to express. You may run into that. Big question about pronouns. And once again, this is a manifestation of gender identity and gender expression. Follow the patient lead. It's the safest way to go. So I'm going to recommend that we ask that on intake forms, and we'll go into that a little bit later. Remember that this may change from visit to visit. Someone may want to identify as he or she, ones that we're much more comfortable with. Oftentimes, people try to come up with a neutral pronoun such as they. For a single person, even they might like that Z or here. And the patient may prefer just using their name instead of the pronoun. If you don't know what pronoun to use, that's the safest way to start. The next thing is to talk about the clinic. I will tell you that I asked my Facebook friends and family to tell me what their experiences were and what their suggestions were for what they wanted out of healthcare provider. And I was shocked to find out the difficulties that these folks were sharing with me. These folks are dealing with a lot of prejudice. We're talking about a minority population here, prejudice and increased physical danger. And what they really want at the bottom of it all is basic understanding and consideration. So the context of this is that as a minority group looking for safe space, they're going to be looking for a sign that they will be safe in your clinic. This doesn't have to be a rainbow flag that you hang from the ceiling in your clinic. It can be subtle, and it's just going to be, they're going to be looking for signs that you are inclusive and that you're a safe place for them to come. One of the things you can do is go into your clinic space and look around and see what the patients will see. What do you have in your art on the wall? Is it inclusive? What kind of magazines and books do you have for patients to look at when they're in the waiting room? And what kind of pictures are on the patient teaching information? What is the wording like? Is it inclusive? If you have subtle hints such as this, the patient will feel more comfortable. They're looking for these kind of things when they come in. One of the things to do is think about how you greet a patient coming into the clinic. Just greet the patient by name, and if they have someone with them, ask them who it is that they're bringing. Let them identify who that person is. Don't make any assumptions. Of course, ask them if they want the other person to come back with them into the room. Remember, there's some increased problem with intimate partner violence, and we want to be very aware of that and make sure that we keep our patients safe. In terms of staff, think about inclusivity in terms of who you hire. I think that people in this community will feel more comfortable if they see somebody who is of this community working on your staff, showing that you are understanding and inclusive of that. Hire diversity if at all possible, and then train all of your staff on your expectations of civility towards patients. Also in the break room, like what is acceptable to talk about at work and what is not, and have a very clear understanding of that. Please think about the restrooms. There are some people who take great risk, especially the transgender folks who take risks going into a public restroom. They may not go to the restroom if it is a public restroom that is shared. And it's kind of an uncomfortable position to ask them to choose if they need to go into the male or female. If you really do have a continuum and understanding in your office, then that shouldn't have to be a choice. And so if at all possible, have individual stalls. And if you don't have an individual restroom, please make accommodations for these patients. If you have an employee restroom maybe that they could use, that would be a really nice thing to be able to do, just to be understanding of that kind of conflict for them. Think about your intake forms. Please ask about gender at birth. It does matter, as we discussed. Ask how they identify now. Ask about what kind of pronouns they prefer to use. Ask about their sexual orientation, and ask about their sexuality, and it's who they have sex with, who their partners are. And you can ask if they have relationships with men, women, and both. If you ask everyone these same questions, it doesn't single anyone out. And it's another way to show that you are inclusive and you understand some of the issues. As a provider, I think the best thing you can do is check your own thinking. Binary thinking often assigns values to one side over another. It actually elevates one side over another when you have a binary thinking. And honestly, most folks don't fit into little boxes very well. And this is true for race, ethnicity, relationships that we have, and then, of course, gender and sexual behavior as well. Allow yourself to think about things on a continuum and not ask people to put themselves into a box. That's very difficult to do. If we could just star one thing in this presentation, it would be not to make assumptions. That was the one thing that people asked me to pass on. Please don't make assumptions. If you see a male, don't assume that they have a female partner and have them explain to you that they don't. Ask first before you just make the assumption. They would really appreciate that. Overall, be nice. This is not really about a dating situation where you're going to try to figure out if you can date this person or if we're providing care. Be nice to everyone that we're going to provide care to, and have it be okay that everyone is who they are and who they choose to be in the world. And then finally, educate yourself. There's some training sites later in the presentation if you're looking for those. There are a lot of resources on the web, and begin to educate yourself and ask people what they want you to know. Be open to that. Finally, in your community, the LGBTQ population often feels isolated and unsupported in their communities, and to be honest, often in their own families even. The LGBTQ youth are looking for positive mentors and role models. Research has shown that this LGBTQ organizations can positively influence this vulnerable population. And think of how your own participation, even in small, could influence your community. Think of how a young LGBTQ patient and their family would feel seeing you show your support outside of the clinic, such as marching in a parade to show support or joining PFLAG and speaking up for people. Think of how you can improve your own community by being a role model and being inclusive and accepting and loving in your own community. Dr. Elsasser actually included this pictures that she took from a small town parade in Oregon, where the providers supported their community by taking part in the Gay Pride Parade. The picture above is the youth that they supported as well. Some of these trainings, easy go-to links here for you. There are so many things on the web. Please feel free to start here and then just do some research. People really want to share this. The community really wants to let you know what they need and want, and is happy to share with you what's important to them. I know this isn't a live session. If you have any questions, Dr. Littlefield, Dr. Elsasser, and I are all happy to have increased discussion about these topics. We're very interested in being advocates, and we hope that this kind of stimulates conversation within the Frontier community and increases our inclusivity to yet another minority group. This is a very important issue to include everyone, patients and providers. We have a couple of references here. Lots of information out there. We thank you for your time and your attention, and for letting us share a little quick overview of some of the issues in the LGBTQ community and ways that we can actually increase our inclusivity about them. Thank you so much.